All right, everybody, Dr. Jenkins here. We are back. So this is going to be the last video. You're probably really happy about that. For the respiratory system, we have gone over the anatomy. We have talked about the processes of ventilation, inhalation and exhalation. And then we've talked about external or alveolar gas exchange. And then we talked about internal or systemic gas exchange. We talked about anatomical dead space and then physiological dead space, all that good stuff. So here for this last part, we have a couple odds and ends to talk about, and then we'll talk about regulation of the respiratory system, and then we'll be all done. This first bit looks fancy, but you can totally do it. This is a curve, the oxyhemoglobin dissociation curve, but don't stress, I got you. We're talking about this because this one curve tells us so much information. And I'm going to walk you through step by step what you need to know. So let's just first talk about what this curve is comparing. I'm going to zoom in. I think I have to sneeze. Hold on. Excuse me. Let's talk about what this curve is comparing. Excuse me. This is comparing the partial pressure of oxygen. Another way of saying partial pressure of oxygen would be saying amount of oxygen in blood. So this is looking at the amount of oxygen in the blood. Yes, more specifically, it's the partial pressure of oxygen in the blood, but that really is a direct representation of the amount of oxygen. And then on the y-axis, we're talking about hemoglobin saturation. Hemoglobin saturation. So we've got to go back for a moment. You may remember that each hemoglobin can hold how many oxygens? Each hemoglobin can hold 4. Excuse me. So we know that each hemoglobin molecule in the blood can hold a maximum of 4 oxygens. So if we say 100% hemoglobin saturation, that means that all 4 spots are taken. So what we're comparing here is the amount of oxygen in the blood with the percentage of hemoglobin that is saturated. The amount of oxygen in the blood is being compared with the amount of oxygen in the blood with the percentage of hemoglobin saturation. This is a direct relationship. Now, I'm just doing this as another way to reinforce, right? So let's just draw the graph out ourselves. So we're looking at, if you remember, the amount of oxygen in the blood, the amount of oxygen in the blood with the percentage of hemoglobin saturated, the percentage of hemoglobin saturation. These are directly related, and you already know this. If I have more oxygen, the more oxygen I have, the higher percentage of hemoglobin saturation. If I simply have more oxygen in the blood, then I can better fill the hemoglobin. So it's a direct relationship. The more oxygen that I have in the blood, then the more hemoglobin I can saturate. So this relationship is nothing new to us. What is new is the shape of the curve. If you look at it, it is not a direct line. I drew it as a linear relationship, but it is not directly linear. It doesn't just go like that. Instead, it rises quickly and then plateaus. So the first thing I would do is I would have an idea of what this curve is relating. It's comparing the amount of oxygen in the blood with the percentage of hemoglobin that's saturated. Now we're going to take a look at the shape of the curve. So the next step is, why is it shaped that way? Why does it sharply rise and then level off? The reason that it so sharply rises is because the shape of hemoglobin changes after the first oxygen binds, making the remaining 3 bind faster. Remember, you're not going to have to write an essay about this. You just have to pick from a multiple choice. So I could ask you a question, something like, why is there such a steep slope in this curve? Because after the first oxygen binds, the shape of hemoglobin changes slightly to allow the remaining 3 to bind more quickly. After the first oxygen binds, remember, each hemoglobin can only bind 4. After a first oxygen binds to hemoglobin, the shape of hemoglobin changes slightly, which allows the remaining 3 to bind more quickly. And that's a good thing. That means that we fill the hemoglobin fast. So we quickly bind the remaining 3. Then, number 3 to think about. Why does it level out? Well, it levels out because there's a maximum. How many maximum can each hemoglobin hold? 4 oxygens. So even if I start to have more oxygen, once all 4 spots are taken, there's simply no more space available. So it levels off because there's a maximum. Each hemoglobin can only hold up to 4. So even there's a point where even if I bring more in, there's simply no place to put them. Now I'm going to move a little bit quickly because I want to make sure I get through all this in our video. But this means that you can stop and go back, okay? Please ignore the arrows. It's a function of bringing it over to my iPad. It's so annoying. And there's my cat saying hello again. There's Kima. Okay, so we've talked about what this curve relates. Amount of oxygen with hemoglobin saturation. We've talked about why there's such a steep slope, because after the first oxygen binds, the remaining 3 can bind more quickly. And we've talked about why it levels off, because once all 4 spots are taken, there's just no more spots for oxygen to bind to. Now we're going to talk about this next part. We can handle a drop in oxygen. I've been talking about this, I think. An important question here is, what's more dangerous to the body? A drop in oxygen or an increase in CO2? And always, always, always the answer is elevated CO2 is more dangerous. Sure, a drop in oxygen can be bad, of course, but the body is much more sensitive to an increase in CO2. The body is much more sensitive to an increase in CO2. And this curve helps us explain why we can handle a drop in oxygen. We can handle a drop in oxygen much better than we can an increase in CO2. So let's just play with some numbers. I'm going to point out a normal value. I'm not going to ask you numbers, but normally, just to make the point. Normal amount of oxygen in the blood is about 100. If I have a partial pressure of 100 of oxygen in the blood, what is my hemoglobin saturation? 97%, 98%. That's normal. But look, if I have a drop from 100 to 60, that is a 40% drop. Whoa. If you have a 40% drop in oxygen, 40% from 100 to 60, If I have a 40% drop in oxygen, I am still 90% saturated. So this curve shows us, minus all the arrows, I know it's hurting my brain too. This curve shows us that even if we have a drop in oxygen, we can still have a pretty high saturation of hemoglobin. Normal oxygen transport can occur even with a pretty significant drop in oxygen. If I have a 40%, that's a lot, 40% drop in oxygen, I'm still 90% hemoglobin saturated. That's good. So we can handle a drop in oxygen. It has to do with, of course, how quickly that slope went up. Now, if I had a 40% increase in CO2, you would be dead. Seriously. So we can withstand changes in oxygen much better than we can withstand changes in CO2. All right, the last thing to talk about. What happens to this curve in certain situations? We're going to talk about what happens when we increase the body temperature or if we lower the pH. And you know what? These arrows are really distracting. So I'm going to go back to this picture. So let's talk about 2 times when this curve may change. And the 2 times when it may change would be an increase in core temperature and or a drop in blood pH. And I bring this up because aren't these 2 things that happen with exercise? Yes. So you might be saying to yourself, well, I don't care about this stuff. But during exercise, guess what? Our core temperature goes up and our pH goes down. We have a buildup of lactic acid. We have a buildup of CO2 in the blood, all sorts of things. When there is an increase in temperature and when there is a drop in pH, the curve shifts to the right. You need to know that. When there's a drop in temperature and or I had that backwards. When there's an increase in core temperature or a drop in pH, the curve shifts to the right. And what that means is when the curve shifts to the right, at the same partial pressure, there's less hemoglobin saturation. Normally at 100, there's 97. But when the curve shifts to the right, hemoglobin saturation goes down. But it does so on purpose. When you're exercising, we actually want hemoglobin saturation to go down because we want the oxygen to be dropped off to the tissues of the working muscles. So it isn't always a bad thing. In that moment, we want hemoglobin saturation to go down because it's dropping off more oxygen to the working muscles. If pH is too low, that's usually associated with an increase in CO2. So we actually want hemoglobin saturation to go down. We want more oxygen to be released because when more oxygen is released, it counteracts the rise in CO2. You don't have to know the why. I just gave it to you so you would have it. You don't need to know the why. But know that in these 2 situations, increase in core temperature and when the blood pH drops, the curve shifts to the right. And that is on purpose. We purposely want to be delivering more oxygen to the tissues. curve shifts to the right. Okay. Now, that was a lot. Please go back step by step. Make sure you know each principle. Now, at the end here, we don't have as much to go through, and I'm going to make sure I point out only what you need to know. Regulation of the respiratory system. Again, I apologize for all the arrows. There's something unique about the respiratory system. We have some voluntary control that is not the same for the heart. If I tell you right now, stop your heart, you can't do it, nor do I want you to. If I tell you to stop breathing, or my cat's gonna, hey, Kima. If I tell you to stop breathing, you can. So we have some voluntary control. I gotta be on cat watch here. We have some voluntary control. This is unique to respiratory. It does have limits. If you hold your breath for too long, what's gonna happen? Your body will pass out, causing you to breathe. So we have some voluntary control. Let's talk about basics. You already know this. What is a way that we can do local control for airflow, constriction, or dilation? If I need to bring more oxygen to an area, the bronchioles will dilate. If I need less blood to an area, the bronchioles will constrict. So that you already know. Let me point out the main control center is the medulla. This is the primary control center. We get some help from the pons. Everything else here is extra. The primary respiratory control center is the medulla, with some help from the pons. Of course, the medulla and pons can only regulate our respiratory system with input from, guess what? The same things we talked about when we talked about blood pressure regulation. Input from chemoreceptors, input from stretch receptors and baroreceptors. I'm not going to get specific this time because we already did. What I want you to know is the thing that causes most of our respiratory changes is changes in pH. The majority of our medulla action, when we need to change respiratory rate, is caused by pH changes. So within the respiratory system, the biggest factor of why we need to alter respiration is pH changes. Which are we more sensitive to? A drop in oxygen or an increase in CO2? We are, by and large, very much more sensitive to increases in CO2. Look, even if we have a rise of 10% of CO2 in the blood, that will cause our respiratory rate to double. The body can withstand changes to oxygen much better. Everything else here is extra. I'm driving home the point. What are we more sensitive to? Increases in CO2. Okay. When we talk about pH regulation, we can do it by breathing out more or less CO2. When we talk about this later in the semester, we're going to talk about two body systems that can help regulate pH, the urinary and the respiratory. So you may not think of our respiratory system as being able to regulate pH, but it can. How does our respiratory system regulate pH? By increasing or decreasing respiratory rate. Let's give an example. If our blood pH goes down, if our blood is too acidic, what will the respiratory system do to fix it? respiratory system will increase respiratory rate. So if my blood's too acidic, remember, acidity is usually associated with too much CO2. So if I have too much CO2, my blood's too acidic. If I have too much CO2, my blood is too acidic. What are we going to do? We're going to increase respiratory rate. That allows me to blow off more CO2 to get rid of it. So always, 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 if blood pH drops, if blood's too acidic, I'm going to increase respiratory rate to blow off more CO2. And then, of course, the opposite is true. If my blood pH is too high, I would lower respiratory rate. But you would just want to memorize this one, and you would know it both ways. How can the respiratory system regulate pH? By increasing or decreasing respiratory rate. All right. Home stretch here. Now, I know we don't talk about pathologies too often, but here it's worthwhile to talk about. Almost all of our respiratory disorders are a result of two types of disorders. Most often, a respiratory problem is either restrictive or obstructive. You're probably more familiar with an obstructive disorder. An example of an obstructive disorder is asthma. And I want you to know that. In an obstructive disorder, the airway is narrow or blocked. It's in the name, obstructive. In an obstructive disorder, the airway is obstructed. In asthma, it's due to chronic inflammation. Instead of the airways being nice and wide open, the airway space is narrowed because there's chronic inflammation. So instead of being able to bring in and out air through a nice wide opening, all the inflammation makes the opening narrower. The airway is obstructed. It's more difficult to bring in and out air. The one that you may not be familiar with would be a restrictive disorder. And the example I'm going to use for a restrictive disorder is pulmonary fibrosis. That's when the alveoli harden. A restrictive disorder reduces pulmonary compliance. Compliance is a fancy word, but it means something rather simple. A compliant lung, having compliance, means that the alveoli are able to expand and recoil. We want the alveoli to be somewhat elastic and stretchy. We want the alveoli to be able to expand and then recoil. That's a proper compliance. In a restrictive disorder, the alveoli might be hardened. If an alveolar membrane is hard and scarred, it cannot expand and recoil. It's too hard. So a restrictive disorder, you might get the proper amount of air to the alveoli. In a restrictive disorder, the airways are not necessarily obstructed. So I may be able to get all the air that I'm supposed to my alveoli. But the problem in a restrictive is that the alveoli can't expand and recoil. So be able to define each and give one example. You can see on an x-ray that scarring. If the alveolar membrane is hard and cracked, of course it's not going to be able to expand and recoil. All right. There's a bunch of extra information on here that you don't need to know. I would like you to know some definitions. I would like you to know hyperpnea. Hyperpnea is an increase in ventilation rate or respiratory rate with exercise. When you breathe in and out, your respiratory rate goes up. That's called hyperpnea. Then I'd like you to know hypoxia and hypercapnia. Hypercapnia is too much CO2. Hyper means too much. Hypercapnia, too much CO2. Hypoxia, not enough oxygen. All the rest are extra. All right. In lab, we went over these volumes that you need to know. For lecture, just make sure you review these. Tidal volume, inspiratory reserve volume, expiratory reserve volume, vital capacity, and residual volume. Be able to know the definition. You don't need to know the amount, just the definition. I give you a bunch. I went kind of down the rabbit hole here. You don't need to know all these. That's it, folks. There is a lot for this chapter. So study, study, study. If you have questions, let me know.